Of course, for the wounds of 3B where the bones are exposed and there's loss of soft tissue cover, a local rotation flap or free flaps are very beneficial. The advantages obviously are early closure, complete coverage of wounds and underlying tissue, and control of infection. Disadvantages being obviously prolonged treatment, multiple surgeries, which would be due to either necrosis at the site of graft or flap and or infection, which leads to further scarring and maybe a cosmetically inferior outcome or a skin condition, which may be unacceptable to some patients. Um, so, with these options, why the need for this study? The center that I came from was a level 2 trauma center, which essentially did not have any plastic surgeon coverage, though it had general surgeon, orthopedics, and emergency uh, surgery coverage. Secondly, the patients that came from this region were poor farmers and day-to-day workers, and affordability was always a question when of offering them a kind of treatment when the plastic surgeons would come and do these cases. Um, Secondly, was accessibility. Most of these patients wouldn't want to travel long distances as the next hospital was about 100 miles away, and hence uh, transporting them via ambulances and they themselves refusing to go were some problems that we were facing. And hence the need for this study. And we decided to review some literature on this. And we were not surprised to find some wonderful paper by Gibson from 1977, who used properties of skin, the viscoelastic properties, which included creep and stress relaxation. A creep is when a piece of skin is stretched and the force applied to the skin is kept constant. The skin will continue to stretch um, depending upon the force applied. And the stress relaxation is basically a corollary to this mechanical creep, wherein the tension is applied to the skin and the distance is kept constant. While the distance being constant, the force applied will gradually reduce. Um, these properties were applied by Bashir, one of the Iraqi war surgeons, who published this paper in the British Journal of Plastic Surgery in 1987, who used K wires, which were aligned longitudinally along the wounds, as seen in the illustration A, and a silver wire which was connected in between these K wires and was gradually turned clockwise to achieve approximation of the skin. He does mention skin necrosis at this site of the silver wire, and this is probably because of the constant pressure or stretch at one point of the skin. One of the other studies by Danlers et al. For closure of fasciotomy wounds used a suture technique near, far, wherein the entry point of sutures would reduce the tension of skin and thereby achieve a progressive, gradual closure. A paper from America by Carrigan et al. Used telescopes to close small wounds. However, it had most one important limitations, which were at the loss of at the adhesiveness of this dressing, and this was because if there would be any wound exudate or infection beneath the strip, and this would be requiring a later procedure of closure using sutures, thereby deeming it unfit for large wounds. Uh, K wires were again novelly used with rubber gloves to achieve approximation. A single center cohort study from China came with this new system called the tension relief system, which was pioneered by Topaz et al. In 2012. They treated about 41 patients, 43 wounds. In this system, they used attachment plates, which were sutured to the skin at regular intervals, and some approximation straps, which passed through these attachment plates, gradually approximating it over a period of 24 to 48 hours, and then achieving closure. Plastic straps were also used in conjunction with K wires by Yontar et al. And they would loop these plastic plastic straps around the K wires and bring about approximation. They would do a second surgery in the form of debridement of these edges once the approximation is done, and then suture it secondarily to achieve closure. They reported a mean hospital stay of 13.5, 13 to 16 days, actually. And hence, we decided based on these our study protocol, we plan to use number 0, number 1 ethanol with the help of tension-free mattress sutures. We would use gamma dressings and betadine usol dressings if needed. We proposed the study to an ethical board and it was approved. So we included patients with especially Gustav Anderson 3A and B and over the ages of 18. The exclusion criteria were patients obviously with vascular injury, patients, pediatric patients, and patients who refused to consent. So in our study, we had 7 patients, 4 males, 3 females. The age group of 32 is mean. All were luckily fit and well with no medical comorbidities. And we especially included patients who had trauma to tibia or leg wounds with or without fractures. A written informed consent was taken. The patient was taken to debridement as soon as possible, and if had a fracture, was stabilized. Mattress sutures were used for tension-free closure and approximation of the wounds, and if the bone was exposed, as in 3B injuries, we would use a betadine usol gauze interposition in between those two edges if we are not able to get any muscular closure, and then took mattress sutures over this. Postoperatively, patients were given elevation over bowler-bond splint and a pillow under the thigh. IV antibiotics were given as per hospital policy, which was usually cefuroxime for 5 days, and VT prophylaxis was given till the patient was mobilized or in the hospital. This wound was then reviewed in every 48 hours, and this was done either in a clean ward dressing room or a minor OT as per availability. We found that the sutures was stretching the skin were loose. We then took under local anesthesia intermittent mattress sutures in between these sutures that were taken already previously, and approximated the skin as much as possible without tension, of course. And the previous sutures were cut. The dressing was done again and liver was elevated. We started mobilizing the patient in 48 hours from the first procedure, and which was non-weight bearing walking, either with a Zimmer frame or with crutches. Sutures were revised every 48 hours till a closure was achieved. So leg wounds, we were able to close up to greater than 10 centimeters, 10 to 15 centimeters. And this wound closure was achieved over a period of 2 to 3 weeks. We did not have any infections, fortunately. The mean stay in the hospital was 7 days. IV antibiotics were given for 5 days. All patients were mobilized on weight bearing after 48 hours. And we did give low molecular weight heparin for prophylaxis for DVT till the patients were mobilized. So these are a few cases. This was a 46-year-old gentleman with a traffic accident, no fractures, but a wound over the medial malleolus. As we know, the skin over this portion is difficult to stretch. Hence, we had to extend the wound proximally and then achieved a gradual closure over a 2.5-week period. This is a case for a 36-year-old lady who, in the third picture, as we can see, is a Gustav Anderson type 3B, wherein the bone is exposed, and hence we had to, with a fracture, and hence we had to put an external fixator and interpose it with a betadine usol gauze, and then achieved closure over 3 weeks period. The third case is a 42-year-old gentleman, no medical comorbidities again, had an undisplaced tibia fracture with fibular fracture with a contused lacerated wound of about 25 centimeters over his anterior medial aspect of the tibia, which was progressively closed. Of course, we had to use betadine usol dressing again because of the exposed tibia there. So large leg wounds are usually treated with grafting flaps, and this results in a boggy swelling or coverage, and of course, donor site morbidity. This requires the expertise of a plastic surgeon. It also needs multiple surgeries in cases of infection and complications of flap, which obviously are dealt with the plastic surgeon. Chances of flap necrosis and graft loss are still high. The technique that we are describing uses the viscoelastic properties, uh, including mechanical creep and stress relaxation, to bring about a progressive, gradual closure, um, which is cosmetically acceptable. And this can be done either after the first procedure, either in a clean minor operating room or a clean ward dressing room. To conclude, this technique is easy to perform, can be performed by an orthopedic surgeon, does not require a plastic surgeon, has an appropriate color match, texture, sensibility, and substantial admixture for an aesthetic restoration. Of course, it requires a longer hospital stay and delayed mobilization by 48 hours. And luckily, we didn't encounter infection. However, we are presenting a very small cheese, and hence there are always chances of infection because of the open nature of these wounds. So the limitations are very small sample size, and we did not luckily have any patients with comorbidities. As we know, patients having diabetes and peripheral vascular disease will definitely affect the outcome of skin closure and the vascularity of the skin. And hence, we recommend a larger sample size study to be performed, especially the patient with these kind of comorbidities, and whether we could use this in these patients as well. However, we can safely recommend this procedure for patients who do not have any medical comorbidities and have wounds even greater than 15 centimeters uh, to achieve closure as per patient compliance in 2 to 3 weeks' time. Thank you for your patient listening.